contagious respiratory disorders. So the first one we're going to talk about is influenza. Um, so it is a highly contagious infection that is rapidly spread from one person to another. The rate of influenza outbreaks vary year to year. The last highest recording was in 2017 to 2018, in which there were 48 million illnesses, 22 million doctor's visits, 959,000 hospitalizations, and 79,400 deaths. And when COVID hit, there were only 16,000 illnesses versus 48 million. That's a drastic drop. And only 224 hospitalizations versus the previous 959,000 hospitalizations, and no reported deaths. So well, that's what happened when COVID hit. So risk factors. Age, young children, older adults, those younger than 2 and older than 65 are at higher risk due to immature or decreased immune systems. Um, those with like health occupation, healthcare workers, daycare providers have a higher instance of being infected with influenza. Some environmental factors, people living in dormitories, long-term care facilities, like in close proximity of one another. Those with immune system compromise, like patients with malignancies who are being treated with chemotherapy or transplant recipients because their immune system is compromised. And then patients with chronic illness like diabetics, patients with renal failure, asthma, cardiac and respiratory diseases, and pregnancy are all risk factors for influenza. So there are three types. There's influenza A, B, and C. Influenza A has two subtypes based on viral proteins. Those are the names right there. The hemagglutinin and the neuraminidase. Influenza A and B are responsible for epidemics of respiratory illnesses in the winter months and are associated with hospitalizations and deaths. They can mutate within the host, making individuals susceptible to different mutated influenza viruses throughout their lives. So every year, basically, the influenza A and B, it's mutated every year. So we kind of really don't know what kind. Yes, it's an A and B, but we don't know which A and B we're going to get because of it's mutated constantly. Once it goes to one host, it's mutated again once it goes through. And then you have influenza C, which there's no symptoms. It's not even really a thing. Um, so the causation of influenza infection is through small droplets from an infected individual sneezing or coughing or by um, touching an object that carries the organism that allows transfer from one person to another. It can happen over a period of approximately 4 to 6 hours. These infected cells reproduce and spread the virus to other respiratory cells, extending the infection throughout the respiratory tract. So the infectious agents are inhaled and become deposited on the epithelial cells of the upper respiratory tract. The incubation period typically lasts about 18 to 72 hours, and then virus shedding usually ends 2 to 5 days after symptoms first appear. The severity of the symptoms and subsequent illness depends on the amount of virus shed during the replication phase and the number of respiratory cells that have been affected in the individual. So it's important to remember that individuals are pretty much infectious for like up to 7 to 10 days based on that viral shedding and based on the incubation period. So signs and symptoms: fever, headache, sore throat, severe nasal congestion, cough, malaise or muscle aches, malaise, and fatigue are the common symptoms. Diagnostics: the gold standard for diagnosing influenza is a sampling of respiratory secretions for a viral cell culture. They can do a rapid cell culture. So, uh, uh, rapid cell culture with the same sample as above. The rapid influenza diagnostic test can be done in less than 30 minutes via a nasal or throat swab. Um, so a rapid cell usually takes about 1 to 3 days for a result, and then again, the uh, the rapid influenza diagnostic test takes about 30 minutes, but they can be variable, and there are false negatives that can happen with those. Treatment is directed toward prevention by getting the annual influenza vaccine, inoculation by looking at the preceding year to project the upcoming year's virus. So it's all a prediction. They're usually right about 80% of the time. The flu vaccine changes every year based on the previous year's type of flu that was seen. Individuals with an allergy to eggs should not receive the typical influenza vaccine as there is an inactive ingredient of egg protein, so they can have an allergic reaction. Typically receive the vaccine early fall, so between October through March. So medications for mild influenza are directed towards symptom relief. There's antipyretics and analgesic for fevers and aches, adequate fluid intake. For more serious forms, they can give antiviral medications can be administered. The name of that is Tamiflu. So they don't cure the flu because there's no cure, it's a virus, but they can reduce severity and duration of symptoms. Um, it will only work if it's given within 48 hours of symptom onset. After that, it's useless to start it. But it can, decrease your, say, if you were to last 7 to 10 days for the flu, it can like make it go down to 3 to 5 days. So that's a lot better. Monitor for worsening respiratory status, dyspnea, wheezing, coughing, skin reactions such as rash, pruritus, and urticaria, and then neuropsychiatric events like agitation and hallucination when you're giving Tamiflu. Primary influenza viral pneumonia is the least common but most severe type of complication. So occurs more frequently in individuals over 65. So because of the flu, they can get viral pneumonia. Signs and symptoms are progressive shortness of breath, persistent fever, cardiovascular compromise. They can have dyspnea with sputum production, have blood-streaked sputum, which may indicate a secondary bacterial pneumonia. This can occur after initial infection due to normal flora within the nasopharynx because they are able to enter the respiratory system because the respiratory systems are altered. They may have purulent nasal and tracheal secretions. Best treatment for bacterial pneumonia are macrolide antibiotics as they provide the best coverage for most organisms. And macrolides examples are erythromycin, zithromax, and Biaxin. Reason they are treatment for genitourinary, GI, and respiratory infections. Typically, again, infection improves. They can have GI disturbances, tinnitus, dizziness, jaundice, and tachyarrhythmias. Contraindications include hypersensitivity from a previous dose, hepatic dysfunction, myasthenia gravis, cautions or renal impairment, liver impairment. Monitor patient, tell them to monitor their infection from baseline and reevaluate. Obtain specimens for culture before. Monitor for side effects and notify MD if they have any of the symptoms listed there. And then monitor I's and O's. Again, give a full glass of water. Take 1 hour before or 2 hours after meals. All right, COVID-19. So first occurrence was in December. Everybody remembers what COVID is. Was in December of 2019. It was reported in Wuhan, China. Identified as a severe acute respiratory syndrome, coronavirus, or COVID-2, so SARS-CoV-2 was the name given. Spread rapidly, and as of June 2022, there were 545 million cases with 6.3 million deaths. It can manifest as asymptomatic, so you can have it and not know, or you can have critical infection. Risk for developing severe COVID-19 include age, those greater than 65, patients in long-term care facilities, patients that are immunocompromised, have cardiovascular disease, hypertension, diabetes, obesity, any respiratory disease like asthma, any autoimmune disorder, mental health disorders, physical or developmental disabilities, and patients who smoke or use substance abuse make you have a risk for developing more severe COVID-19. So pathophysiology, it is an enveloped RNA virus causing respiratory illnesses ranging from the common cold to acute respiratory failure. SARS-CoV-2 binds to cell receptors and deposits messenger RNA inside the host cell using ACE2 receptors. These receptors are found in cell membranes in the lungs, heart, kidney, and intestines. The cells are released and continue to replicate until the infection is gone. Main mechanism of transmission is through close contact with respiratory droplets from sneezing, coughing, laughing, singing. Infected droplets can land in the eyes, nose, or mouth. So signs and symptoms can range from, again, you don't even know you have it, to life-threatening. Can develop from 2 to 14 days after exposure. Symptoms can include a fever, cough, rhinorrhea, dyspnea, tachypnea, headache, fatigue, myalgia, loss of smell and taste, and GI disorders to include nausea, vomiting, and diarrhea. So again, here they are. Classification of them. So asymptomatic, um, the COVID acid test is positive, but they have no signs and symptoms, and they have normal chest imaging. Mild signs and symptoms of acute upper respiratory illness, a fever, myalgia, cough, rhinorrhea, sneezing, sore throat, and or gastrointestinal symptoms. Moderate pneumonia symptoms where they have fever, chest congestion, cough, tachypnea, dyspnea. They don't require oxygen supplementation at this point, but they do have some abnormal chest imaging. Maybe less than 50% shows of their chest x-ray shows lung infiltrates. Severe pneumonia with evidence of hypoxemia, so their SpO2 is less than 92% or more. Respiratory rate is greater than 30 breaths per minute. They're going to have new or escalating oxygen requirements, and then chest imaging is going to show greater than 50% infiltrates. And then critical patients have acute respiratory distress syndrome, or ARDS, a shock state where septic shock can represent virus-induced distributive shock. They can have cardiac dysfunction and inflammatory response. So they can have cardiac, hepatic, renal, central nervous system, or thrombotic disease in this state if they have critical COVID-19. So the gold standard diagnostic is the polymerase chain reaction, the PCR test, performed via the nasopharyngeal swab. And that's polyamers, I'm sorry, chain reaction test. Additional testing can be chest x-ray for pneumonia. CBC can be done to see if there's white blood cells elevated and anemia. The CMP can be done to like the electrolytes. So we're looking at all their electrolytes to see if any of them are depleted. ABGs to look at their breathing ability. The lactate level determine susceptibility to shock. Coagulation screening, we can see if they're having any clotting disorders. Inflammatory markers, which shows inflammation within the body. Ferritin, which is a protein that stores iron. Diabetics who have an increased ferritin will have been shown that they have increased chance of poor outcomes if they have COVID-19 diagnosis. LDH, the lactate dehydrogenase, it shows tissue damage. If it's increased, patient will most likely will have an increased risk of severe COVID. You have CK, which is creatinine kinase, and creatinine kinase MB, which is a muscle damage marker for cardiac muscle damage. We have troponin, which is a cardiac marker to see if they will have like cardiac disorders with the COVID-19. And then obviously blood and sputum cultures, because if it is pneumonia, it can go and cause a gnarly infection for these patients. So treatment, no cure currently for COVID-19. They're just supportive, so oxygenation, supportive respiratory care if they have to be on mechanical ventilation, antipyretics, analgesics, fluid intake, and rest. And here are some meds that they were tried on, especially Paxlovid and Remdesivir. Those were the two biggest ones that were initiated for patients in the hospital area to help decrease their case of COVID-19. And then the biggest complication of COVID-19 is acute respiratory distress syndrome. Be alert for patients with dyspnea, increasing oxygen requirements, increased work of breathing. Most likely these patients will have to be put on a ventilator so that the machine can breathe.